effusion. And at last, I'm going to give you one rare case of pleural effusions. So this is a question given to me when to refer to chest physicians. The answer is very simple. All recurrent pleural effusion with unknown etiology should be referred to chest physician for further workup. So these are causes of pleural effusion. As you know, most of you know that it can be divided into transudate and exudates. And sometimes you get rare causes like urinothorax. Hemothorax is quite commonly seen in malignancy and patient with trauma. Chirothorax, which is milky white pleural effusion, which also seen occasionally. I won't touch into causes of transudative and exudative effusion. I think most of you know about this, and we're going to discuss along the way. These are simple algorithm of diagnostic workup of pleural effusions. I think the most important is the medical history and physical examinations. And if you think that based on the physical examination and history, it looks like it's a heart failure, for example, you probably do not require any more workup. You can actually treat as such a heart failure. And if the patient, if pleural effusion actually resolved, then your diagnosis is correct. But a lot of time when the patient has pleural effusion, diagnosis is uncertain with medical history and physical examination. So you may need to do thoracosynthesis. That is to know whether it's exudative, transudative. If it's past, then you know it's empyema. If it's milky white, you know it's a chirothorax. And a few investigations may be useful, like for example, CT scan, ultrasound, and bronchoscopy, and etc. So if you still cannot certain what is the diagnosis after thoracosynthesis, a lot of time we will do pleural biopsy. You can do pleural biopsy, either blind pleural biopsy using Abram needles, or you can refer to us for thoracoscopy. And very occasionally, we cannot diagnose the cause of the effusion that we need to send to the surgeon for thoracotomy. This is light criteria. I'm sure most of you know about light criteria, and I'm not going to go into detail, but just want to share with you that light criteria have a sensitivity of 98% and specificity of 83%. What does it tell you? It tells you that if it tells you it's exudative effusion based on light criteria, it still can be transudative cause. So vice versa. So that's why I think you cannot sort of 100% confirm just by light criteria. So if you get a transudative effusion in a patient with liver cirrhosis, for example, if effusion is not resolved with treatment, you still have to investigate further. I think a lot of time we do thoracoscopy, and it could be pleural TB, for example. Let's discuss about a few cases. Share with you the first case first. We have this 35-year-old man who actually presented with fever, low-grade fever for a month, cough with yellow sputum. He also got left-sided chest pain, and he lost about 3 kilos in 3 months. There's no night sweat, there's no TB contact. He feel better after a short course of antibiotics. So this is his chest X-ray. If you can see the chest X-ray, there is a very nice loculated effusion here. A nice, what we sometimes call it pregnant lady sign. And this to illustrate that this patient has loculated pleural effusion. And a lot of time loculated effusion is because of very chronic effusions. So what is your diagnosis at that time? I think the two main diagnoses, because the patient has fever, low-grade fever, you got to think about whether this could be parapneumonic effusion or empyema, or this is tuberculosis effusion. How are they going to differentiate between these two? Thoracosynthesis is very important. So most of people will do thoracosynthesis. And if it's neutrophil predominant, then you know this is likely to be bacteria. And a lot of times the sugar and the pH can be low, and white cell count usually is very high, more than 10,000 per cubic millimeters. And gram stain is very important. Always do gram stain when you suspect parapneumonic effusion, because the culture can be negative, especially a patient given antibiotics. TB is another common cause of patient with effusion and fever. And commonly they are lymphocyte predominant, sometimes monocyte. And ADA can be high, but a lot of time we don't do ADA here. Diagnostic here depend on what methods that you use. If you want to rely on AAB direct smear, I think it's almost always negative. So it's no point actually to wait for the AAB direct smear to come back if you want to diagnose TB effusion. And TB culture can be positive up to 20% of the time, but it takes about 2 months for the result to come back. So I think the few more investigations are more useful in TB effusion. One is gene expert. You can send a pleural fluid for gene expert, which will give you yield probably about 43%. And you can do pleural biopsy, and then you send for gene expert. That will give you higher yield, 85%. Pleural biopsy is definitely one of the investigations which is very useful, especially if you got no access of gene expert. You can actually do blind pleural biopsy using Abra needles. The yield is about 60%. Or you can refer to us for thoracoscopy, which the yield is very high, which is 95%. So what happened to this patient? We actually did a CT scan, and you can see the CT scan. There's a multiloculated effusion, and the usefulness of CT scan is actually to exclude malignancy and also to confirm loculation. You know where is the locule, that is easier for you to stick a needle in before you do thoracosynthesis. So what we did was we did a thoracosynthesis, and you can see actually pus came out, and it was positive for gram-positive cocci. And this patient, what happened was culture was negative. As I say early on, gram stain is very important, and we also sent for gene expert, it was negative. Beware, empyema also can be due to TB. I've seen 2 cases of TB empyema. Good things, TB empyema, a lot of time there are a lot of AFB, so AFB direct smear was positive for these 2 cases. So this patient had empyema and it's bacterial cause. So how we manage empyema due to bacteria? When are we going to drain the patient? There's these algorithms that you can see, that you can divide the effusion into a parapneumonic effusion into a few categories. When they are category 3 or 4, then you need drainage. What is category 3 and 4? You just remember when you do a thoracosynthesis, if the gram stain is positive or the culture is positive, or with the pH is less than 7.2 and the sugar is less than 2.2, then this patient requires drainage. Or when you drain, it's actually pus, then this patient need drainage by chest tube. If the patient is category 2, these are what we call simple parapneumonic effusion. The definition, if there's quite significant fluid, but it's less than 50% of hemithorax, no loculation, and the thoracosynthesis did not show any positive gram stain, and the pH is more than 7.2, this type of patient can be treated just with antibiotic and do not require drainage. So how about antibiotics? What antibiotic are you going to use if you've got a patient with parapneumonic effusion? It all depends on whether this is a commonly acquired pneumonia, CAP, or this is hospital-acquired pneumonia. So you will choose the antibiotic to tailor to these conditions. Usually, parapneumonic effusion or empyema is actually not due to atypical organism like mycoplasma and etc. The preferred antibiotic, if you want to give antibiotic, I prefer Omentine or Unacin, because you have an oral form. You can give IV first for a few days until the fever settles. If the fever settles more than 24 hours, you can always change to oral. As compared, the duration of antibiotics, if it's simple parapneumonic effusion, 1 to 2 weeks should be adequate. If it's complicated, when there is a loculation, when the pH is low and the sugar is less than 2.2, then you can probably give a bit longer, which is 2 to 4 weeks. If it's empyema, then you give 4 to 6 weeks. How about intrapleural fibrinolytic agents? And this have been shown to be quite useful. Some meta-analysis have shown that you actually, especially when you see a complicated parapneumonic effusion or empyema, you actually can put fibrinolytic agents. The common agent that we use in my hospital is streptokinase because it's cheap. Of course, the best based on the clinical trial is the TPA as well as DNase. And by giving fibrinolytic agent, you can reduce the risk of surgical intervention as well as mortality. If you fail drainage by chest tube and you fail fibrinolytic agent, you actually can refer to surgeon for video-assisted thoracosurgery. And a lot of times the surgeon will do adhesiolysis, they will do some deployment, and they will do decortication as well for lung expansion. And the success rate is very high. And if you fail, a lot of surgeons will actually do an open thoracotomy. Okay, that is about the first case on empyema. Let's discuss about the second case. This is my patient, 56 years old lady, non-smoker. She presents with cough, loss of weight, and loss of appetite. Clinical examination show clubbing. Of course, there's a sign of pleural effusion as well. Chest X-ray show left-sided pleural effusion, which is quite massive. It's probably more than half of the hemithorax. So what you need to do, if you see clubbing, any patient who has clubbing, you got to think about carcinoma of the lung. We have a few cases that a patient presented with apical mass, with or without pleural effusion, and the patient had gross clubbing, but was treated as pleural TB. But anytime when you see clubbing, you got to think about likely cause of the pleural effusion is actually due to carcinoma of the lung. So what you can do if you are in the district hospital, you can drain out the pleural effusion, and then you repeat chest X-ray. Sometimes you can see the mass beneath it, or you can straight away do a CT scan, and that's what we did, and we found there's a mass over the left lower lobe with effusion. There's a lot of mediastinal lymphadenopathy. So what's the best investigation? Subsequently, are you going to subject the patient for bronchoscopy? You can, of course, do a bronchoscopy. If from the CT scan, look like it's a peripheral lesion, you actually can do transbronchial lung biopsy. Or you want to do bronchoscopy because there's a lot of mediastinal lymph nodes. You can do what we call EBUS TBNA, transbronchial needle aspiration. And with the ultrasound guidance, we have a special scope that at the tip of the scope, there's an ultrasound probe that you can actually ultrasound the mediastinum. Or you want to do a pleural tap, looking at cytology, or you want to do a blind pleural biopsy, or you want to do medical thoracoscopy. So, but what I want to tell you is very important thing is if you're sampling the primary lesion, you just give it a diagnosis. But if you're sampling the metastatic site, like for example, pleural effusion or lymph nodes, that will give you staging as well. So I think that is probably more important. So a lot of time, what we do is we try to look at the metastatic site rather than biopsy the primary tumor if there's a metastatic site. So if you do pleural fluid cytology, I suggest you do 3 times and send enough fluid, like for example, 50 to 100 mils. That will give you the yield probably higher, is about 75%. But the problem is a lot of time when you send pleural fluid cytology, it may not be enough for molecular testing. So you can do pleural biopsy, but using blind pleural biopsy, the yield is probably out to 60%. In fact, the pleural biopsy, blind pleural biopsy yield is actually lower than pleural fluid cytology times 3. So the best is still for us is actually medical thoracoscopy. It gives you a very high yield, which is 95%, and you can actually do pleurodesis at the same time. The very minimal side effect, and a lot of time is probably the side effect of the sedation, and sometimes a bit of pain and infection at the site of the thoracoscopy. So where we do thoracoscopy, we usually do in the OT. There's a special design scope that by Olympus. And what we do is we actually make a small cut on the skin and then put a trocar in. And you can see this trocar here. Then there's a special design scope. Then you can put a forceps in and biopsy the parietal pleura. We try not to biopsy the visceral pleura because it can cause pneumothorax. But if the lesion is big enough, you actually can biopsy the visceral pleura as well. So that's how pleural nodules look like. And this page, like in this case, there are multiple nodule scenes. So if you do a blind pleural biopsy, you probably can actually get the diagnosis as well. But sometimes you only see 1 or 2 nodules on the pleura. So that's why the medical thoracoscopy becomes very important. You imagine that in this case, if you do a blind pleural biopsy, you may not hit the tumor. So what we did was we did a medical thoracoscopy, and then there were multiple nodules seen. So we actually did a biopsy. 2 weeks later, this patient came back with another massive pleural effusion. Because after thoracoscopy, then with the chest tube, the effusion actually resolved, but very fast, the pleural fluid actually reaccumulate. So at that time, we traced the result. The biopsy result showed adenocarcinoma, and EGFR was positive. There's an EGFR mutation. And what to do next? Because the patient is breathless. So there are many things that you can do. Of course, you can repeat thoracosynthesis. Just stick a needle in, drain as much as you can, but try not to drain more than 1.5 liter because you're worried about re-expansion pulmonary edema. You can do tau pleurodesis with thoracoscopy, go in again and do tau pleurodesis. And you can do medical pleurodesis, put a chest tube in, drain out all the pleural fluid, and then put tau inside or put some sclerosant. Or you can actually put enduring catheter for the patients. Or is there anything else that we can do which is better than the A to D? Let's discuss about this. So what is pleurodesis? Basically, we actually put sclerosant into the pleural cavity so that the visceral pleura and parietal pleura can stick together, and so that the effusion will not reaccumulate again. The side effect is usually pain, fever. ARDS have been associated with a few cases that when they use tau, which is not, the particle is too fine. So that's why when you want to do a pleurodesis with medical tau, you should actually get a FDA-approved tau rather than just simply buy from any company. Some patients may not respond very well to pleurodesis, especially those patients with multiple adhesion, multiple loculations. if the pleura is very thick or the pH is very low. So these are sclerosant, but the best based on Cochrane review is TALP. So we use TALP most of the time. You can put in a long-term indwelling catheter. I don't like this because I don't like to have a catheter in the body, and this is a bit like Tenco catheter. Of course, it can cause infection over the skin. The tract can get infection, or you can even cause empyema or infection in the pleural cavity. And but this has been shown to be quite useful, especially those patients that you try pleural disease and fail. So what we did, because this patient had EGFR TKI, this patient EGFR positive, we started gemcitabine and pleural effusion dissolved completely. So I think this is a good thing about targeted therapy in lung cancer. So you can see that it's very effective drugs, and the pleural effusion can resolve completely with these drugs. So you probably do not require pleural disease or indwelling catheter with this case. Okay, I'm going to show you the last case. This is a 35 years old lady. She actually got recurrent pleural effusion, usually require admission monthly in one of the private hospitals here in Kuantan, and she had repeated drainage for the past 5 years. Finally, I'm not sure why, someone saw her and then decided to send to me, and the chest X-ray at that time showed hydropneumothorax. So I did a pleural tap for her, and first time I saw this, the fluid is actually not really hemorrhagic. It's dark chocolate color, a bit like coffee ground. And then I asked her a few more questions, and the diagnosis is quite certain. And this was the first case that I saw in my respiratory career. So I did a thoracoscopy for her, and you can see that this is chocolate color nodules that you can see everywhere. I'm not sure anybody want to answer what is this. Anybody want to try? There are some participants here actually.
Endometriosis.
Yeah, actually this patient had endometriosis of pleural cavity. It's very rare, it's not common. And this is the first case that I saw and the only case until now. So I sent her to a surgeon, and surgeon did a parietal pleurectomy with composite mesh coverage on the entire diaphragm. And after that, there's no recurrence. She's very well. She's still under my follow-up. So this is my conclusion. Recurrent pleural effusion is common. Reference to chest physician is essential, especially when diagnosis is uncertain despite investigation. Thank you. I would like to take questions. Are there any questions?